Paul, I have some very sad news. The inventor of Hall's cough drops died last night.
I'm sorry to hear that, Matt.
And Paul, there won't be any coffin at his funeral.
Oh, that's great.
Yeah, it's pretty good. What do you got?
So we're doing the travel medicine show, Matt, and I quick tried to look up traveler's diarrhea puns. And I've landed on hahajocks.com / funny diarrhea jokes. And I'm just going to give you a sample. I'm not going to say a taste, but why, Matt, why did diarrhea go to the party?
I don't know.
To bring a little extra splash to the fun. There are like 300 of these, Matt. What? Why did the diarrhea bring a suitcase?
I don't know.
It was planning a long-term stay. So anyway, AI will save us all. Great website. Congratulations to Haha Jocks.
The Curbsiders podcast is for entertainment, education, and information purposes only, and the topics discussed should not be used solely to diagnose, treat, cure, or prevent any diseases or conditions. Furthermore, the views and statements expressed on this podcast are solely those of the host and should not be interpreted to reflect official policy or position of any entity aside from possibly Cash Life Moral Hospital and affiliate outreach programs, if indeed there are any. In fact, there are none. Pretty much, we are responsible if you screw up. You should always do your own homework and let us know when we're wrong.
All right, welcome back to the Curbsiders. I'm Dr. Matthew Frank Watto, here with my great friend and America's primary care physician, Dr. Paul Nilsson Williams. Some good puns tonight, Paul.
Yeah, great stuff.
Good discussion of humor. Sometimes we say funny things on this show, I guess.
It's invariably, Matt, the letters we get are, thank you for making me laugh and learn. And I have to wonder where the laughter comes in, but God bless them anyway.
At least I'm laughing sometimes at your disgust with the terrible jokes. On tonight's show, we are going to talk about travel medicine. This was, of course, featuring returning guest, Dr. Bahuma Tatanji, with super producer, Dr. Beth Garbatelli. And Paul, this turned out to be a great episode. Lots of great stuff, but let's start with some general travel tips. Now, Paul, it doesn't matter who I am. When I'm traveling, the only thing that matters is preventing infections. Is that true?
Yep. No, Matthew. So it's to your point. I think where this comes from is I know that I think early on in my career, someone would come in and say, listen, I'm traveling to this country. I would immediately go to the CDC website. I would look at what infections they're at risk for, and I would go after those. So I think that's not an uncommon mindset, but it's interesting that people who do these travel clinics for a living or do them fairly frequently look at a much bigger picture, not surprisingly. And Dr. Tanji talks about being interested in the substrate in addition to what she's trying to prevent. So she views it in terms of who is going on the trip and then where is the trip going to. So, and then combining those two factors, it's probably worth mentioning that, the mortality that happens when people are traveling is usually not from infectious diseases. It's usually the type of mortality they would have if they were at home. So if someone has high risk for heart disease, a heart attack might be the thing that is most likely to take them out. And accidents and injuries for younger folks, driving in unfamiliar locations, not looking the right way before trying to cross the street. Like these are the things that can actually are more commonly going to seriously hurt people. And the infections tend to be sort of mostly an inconvenience, but it's still worth actually thinking about. Yeah, so I'll pause there and see what your take is on this.
Yeah, the reason I made that joke to open up is because I totally missed that as a point, and I thought, it was interesting that she wanted to start there before she would even get into talking about infectious diseases with us. Now, if people are traveling, the CDC Yellow Book, which the online version is what we would recommend because it's continuously updated. But I guess there are physical copies, though I've never seen one. I'm sure there are. The other site she said that she likes is UK's Fit for Travel. And then if you're going to a place, it's probably worth looking at like the WHO's website just to see if there's like disease outbreaks in the news. That's going to be like most up to date, even maybe before the Yellow Book or the other sites are updated. So definitely check those out. And then make sure that the person has a good plan for travel as far as they have refills of all their medications and enough medication to get them through the duration of their trip. And they might want to purchase travel insurance, especially if they're older and sicker. or just the longer you're staying in a place, I guess the more time there is for something bad to happen. So travel insurance, even for a young, healthy person, if they're going to be somewhere for a really long time, might be worth getting. Now, Paul, when people travel, no one's having sex, right? We don't have to worry about that.
It's, I love this framing especially. Yeah, no, Matt, to your point, it's kind of known that when people travel, they're actually more likely to engage in higher risk behaviors in general, and so that sex can be one of those behaviors, and it's probably worth non-judgmentally offering things like pre-exposure prophylaxis, post-exposure prophylaxis to the appropriate patients, as well as just giving a handful of condoms. And sort of, you can ask about sexual activity, but you should just offer these things and just think about ways of preventing downstream complications from higher risk behaviors in advance, because people sometimes behave differently when they travel, and that can also extend to substance use even. So just sort of counseling around alcohol use or other substance use, it's just worth being proactive and having conversations about ways to deal with those things safely while you're abroad, because you don't have the same resources that you have when you're at home, and doing so in a non-judgmental way, recognizing that people's behaviors can be very context dependent, I guess is a nice way to say this.
Yeah, I think that's true. I mean, this is another point that I wouldn't have heard of as much, but like reading about travel medicine, there's a lot of talk about, just thinking about like medical tourism, sex tourism. Like people travel for different reasons other than just to sit on a beach somewhere. So, you definitely need to ask about what they're going for. But my head always jumps right to malaria, Paul. So I do want to spend some time talking about malaria, and we spent a lot of time with Dr. Tatanji talking about malaria. So, Paul, mosquitoes, they can bite at all times of day. So even if you're using insect repellent or the insecticide treated bed nets, it's hard to avoid mosquito bites. So patients that are going to an area where malaria is endemic, they should be getting malaria prophylaxis. Even if they were born there, if they've been outside the region for more than 6 months, it's something that they should still take. And I think that's where probably a lot of people don't think they need it, right? Because they grew up someplace. So
Sanji made that point. She's like, those are the patients most likely, because they're the people who have never had malaria are terrified to get it, and the people that have immunity are not worried about it. It's the people that had immunity and are still blasé about it but have lost immunity, or that are the ones that are probably most likely
yeah.
to actually end up with malaria.
Yeah, and it's such a short time, like 6 months. So I mean, if you move out of the country and then you go back to visit, like most likely you lost your immunity.
Yeah.
And I mean, we talked about there's like five subtypes of malaria. Falciparum, Plasmodium falciparum is the big bad, and then there's ovale and vivax are the other two common ones that at least I hear of most commonly.
Yeah.
And we even talked about at ACP how there are some cases of malaria that were in like I guess the southern United States that have been documented over the past few years. We don't think it was falciparum though. I think it was either ovale or vivax, which was there. But she did mention that it's possible if someone came back with malaria and mosquitoes are feeding, like it's possible it could start to be transmitted here as well.
Right. Thanks to global warming. So it's apparently our local mosquitoes are not as good as Anopheles at transmitting it, but they can still do the job if they need to. So as the temperatures creep up, don't worry, we'll eventually be seeing probably plenty of falciparum here. So
Yeah.
exciting times.
Yeah. So, and the falciparum mostly for right now though is in sub-Saharan Africa and a little bit in Southeast Asia. Now, Paul, the daily medications or the weekly there's daily and weekly medications for treating malaria. Are you, as America's primary care physician, are you prescribing this in your clinic, or is this something that you're sort of deferring to the travel medicine clinics?
I will prescribe these medications. I think I even mentioned this in the episode that oftentimes it's someone who has experience with them, and they'll say, "Listen, I'm going to be traveling. I've taken a topical and Perguanil in the past, and could I please have a refill of this medication because I'm anticipating traveling in the next coming months?" And I'm like happy to do so. I have less opportunity to be more selective or sort of think critically and initiate the medications, but there are times when I do get to prescribe
Yeah.
prophylaxis, as it helps to be a little bit passingly knowledgeable about them. But it tends to be the daily rather than the weekly.
Yeah. So the daily ones, the options are doxycycline, which I think most primary care physicians are more comfortable prescribing. You wouldn't give it to a pregnant woman or a child, but otherwise, doxy's okay. And she made the point that if someone is traveling and they're going to be hiking a lot, that may be a good one if there's going to be tick exposure because it could also prophylax against other vector-borne illnesses. But you got to really counsel people about sun exposure, especially. I mean, anybody could get sunburns taking doxycycline. I've actually experienced this when I was young and dumb and taking doxycycline for acne. I got really bad sunburn just on a normal day outside. So it is a real thing that happens. But yeah, so doxycycline is one of them. Atovaquone proguanil tends to be the one that I see prescribed most often. And these daily meds, Paul, they can be started usually a day or two before the people leave, and then they're continued for about a week or so afterwards. Definitely look up the specifics when you're prescribing them. But these medicines, I think, especially if someone can't make it to the travel clinic or there is cost associated with a travel clinic. So as a primary care, I think it would be nice if you could prescribe these. And after listening to the full episode and talking with Dr. Tatangi, I think, I feel comfortable now doing this. Primaquine, Paul, what's the problem with that? Now, people that have G6PD, they're good to go with Primaquine. No issues there.
So I was thinking about this, Matt, as you're sort of switching up your delivery, because you're like, so mosquitoes bite people all the time, and I'm so used to you saying the wrong thing. I'm like, wait, but they do. So like I had to actually pause and sort of course correct in my brain. So when you say something now, I have to assume that it's incorrect. But so where are we going with this? Oh, the Primaquine. The issue is, Matt, is that you do have to do testing for G6PD deficiency, which can take some time and can be a little bit of a burden. So it's not Primaquine is limited by the need to do that testing. So I suppose if you know that status, then it would be easy enough to start. But unless you do, oftentimes you're limited in prescribing it because you don't know if someone has G6PD deficiency or not.
Yeah. Yeah. And then she did say the other cool thing about Primaquine, because it treats the liver stage of the disease and it's kind of unique in that fashion, you can use, it's called terminal prophylaxis is what I found, Paul. So that like if someone comes back and they're like, yeah, you gave me that atovaquone proguanil, I didn't really take it that consistently. You can give them 14 days of Primaquine as like terminal prophylaxis to just sort of eradicate any malaria that's taken hold in their liver and might like reactivate at some point and cause them to get ill. So I thought that was pretty cool.
That's very cool.
Weekly meds include mefloquine and chloroquine, and then one other one that we're not going to mention because it's new and fancy, and even Dr. Tatangi says it's hard to get your hands on. So not necessarily something we need to know about for this episode. But mefloquine and chloroquine should be started 2 weeks before travel and continued for a month afterwards. So, but they're weekly meds, so it's less pills overall. It's just a longer duration of time that they're going to be taking it. I don't have experience prescribing this yet, Paul, but I'd be open to it. I mean, she gave us most of the tips we need to how to do this. The big thing about chloroquine is there is resistance, so you really have to know like where they're going, and there's only specific areas where chloroquine would be an option, but mefloquine could be an option. And then, Paul, people that have seizures and cardiac rhythm disturbances, is that a problem?
Yeah, they should not be on these as well. Yeah, and I will also mention to our board-taking listeners that I feel like the mefloquine nightmare question is asked on every single board I've ever taken. I don't know why, since I've never prescribed it, but worth knowing about.
So she basically said people with like really bad neuropsychiatric illnesses, there are some neuropsychiatric side effects, including severe nightmares with mefloquine. So you should, you might not prescribe that to somebody that's like may decompensate psychologically. So that might be a limiting factor. And then, Paul, if somebody's traveling and you're worried about their ability to adhere to the medication, can you say the name of the medication that we would use to treat malaria if someone were to get it?
I can sure try it, Matt. So Dr. Chenangia talks about she will sometimes send patients who have high risk for malaria, so those patients who might not be adherent, with artemether lumefantrine, we're going to say, and the brand name is Coartem. So I suppose I would have said it faster. I may have gotten away with it, but she will sometimes send patients with just treatment in hand, just in the off chance they should develop malaria while traveling abroad, because it's getting to treatment can also be a little bit of a challenge while traveling.
Yeah. And then she just made the point, like, fever in a returning traveler is malaria till proven otherwise, which I think makes sense.
Yeah, I think she said there's like a 1, 2, and 3 on her differential, kind of like the rules of Fight Club.
So, Paul, let's move on and let's talk about how much I love to eat street food. And this is not a problem, right? Nothing bad's going to happen to me.
Now, what is your favorite street food? I'm curious.
It's probably something raw and recently killed.
All right. It's going to be like boiled hot dogs. But yeah, so it's The street food, we had this conversation before, but the street food is a great way to engage with local culture. Unfortunately, it's also a great way to be engaged with the local microorganisms that cause travelers diarrhea. So while it is romantic and kind of cool, it's also probably your best way to actually get sick. So you have to kind of weigh the risks and benefits against that. So as a physician, probably you have to at least caution and give advice. The street food can indeed make you sick, and also raw foods can do it as well. So Dr. Tananji, I think, mentions ceviche specifically, and God bless the hero who has the courage to travel abroad and try street ceviche. But that might be a recipe for traveler's diarrhea. The other sort of counseling that you can do around eating abroad is if you're not sure, just make sure that you're using bottled water anytime that the water may actually be in contact with your GI tracts. That includes for things like brushing your teeth, rinsing off food, and then also just when you're for general drinking, including ice cubes, are a potential way to actually be exposed to local water. So probably avoid ice cubes unless you're sure they actually came from bottled water. You actually know their provenance, because these are all ways to be exposed to organisms that may make you feel not so great.
All right, Paul. So now when I get my traveler's diarrhea from my street ceviche,
Uh-huh.
what what are you going to treat me with? Ciprofloxacin?
I no. And Street Ceviche would be an incredible name for a band, by the way. So that's out there for anyone who wants to take it. But I think in the back of my brain, Matt, maybe this is because I'm old, but I feel like Cipro was always kind of my treatment of choice for traveler's diarrhea, just to kind of send patients with. But actually, azithromycin is now the preferred medication, and it's worth noting. I'm doing too much talking this episode, buddy, but it's worth noting that you don't need to treat mild traveler's diarrhea, and you can kind of grade traveler's diarrhea by how much it's impacting your life. So mild is kind of annoying, but does not disrupt your day to day. So if you have plans, you can still go out and do things. You just may have the rumblies. Moderate traveler's diarrhea. This is where you might consider actually giving someone like that. Someone might actually self-medicate with the azithromycin you prescribed for them, and that is something that is disruptive to your day. You're having a hard time sort of staying off the toilet, and you can't go about the day-to-day things that you had planned. And then severe is if you're just like confined to your hotel room, or if there's blood in your stool. Those two things put you in the classification of severe diarrhea. And then in addition to treating with antibiotics, you need to be thinking seriously about your rehydration strategy, and maybe even getting some medical attention above and beyond that.
And I just wanted to mention, like, if someone is having moderate or severe diarrhea, homemade oral rehydration solution, the UVA has a handout that I'll link to in the show notes for this, but it's pretty easy to make. So it's 4 cups of water, half a teaspoon of table salt, and 2 tablespoons of sugar. Or my favorite would be just a 32-ounce Gatorade, and you put half a teaspoon of salt in there, and there you go. World Health
Wow.
Organization. I'm not buying Pedialyte anymore, Paul. I'm just gonna put half a teaspoon of sugar in Gatorade, and then that's your oral rehydration solution.
I don't even think you're kidding, is the funny part about this.
I'm not. I mean,
Yeah.
I'm not kidding. It's anyway. I think we should do that in hospitals when people have diarrhea instead of giving them IV fluids. Right now, there's an IV fluid shortage, and I don't know why we're not doing this.
Yeah. Yeah. Yeah.
So let's end by talking about vaccines, or at least end this part by quickly talking about vaccines. So most of the vaccines should be given in the PCP office. So updated things like tetanus, and if they're not immune to Hep A and Hep B, get them vaccinated against those. Those are going to be covered by insurance as preventive vaccines in the primary care office, but they'd be very expensive if you got them in a travel clinic. Now, Paul, yellow fever vaccine, that is recommended for travel to some countries. What do we need to worry about with that one?
Yeah, not just recommended, but required by some countries, and yeah, or documentation that you have a medical contraindication to it. So a couple of things: it can only be given in certain licensed clinics. So this is not something. It's not going to be hanging out in your primary care office just for you to give willy nilly like a flu vaccine. This requires a special circumstances and special dispensations to give it. It also carries a significant, well, significant might be overstatement, but does carry a real risk of side effects. And that risk goes up the older and kind of frailer you are. So especially for older patients, the side effects can include things like, oh, I don't know, Matt, death, which seems like, a pretty significant side effect to be concerned about, especially once you sort of cross, like, I think it's like the age of 75. Did I see? Correct me if I'm wrong, but sort of in any case, the older you get, the more side effects, the more serious those side effects can be. So it's worth getting some counseling about those, but you're not going to be giving those in your local primary care office. That also require a licensed clinic to give the yellow fever vaccine.
Yeah. No, I don't have much to add there. I mean, it's just the older patients. I don't remember the specific age cutoff, but older adults, you would worry about having a more severe reaction to it. And then we talked about the dengue vaccines, and I looked this up after the fact, and like actually, it seems like they're going to stop producing the dengue vaccine, the one that's currently out, but there are some new ones that are going to hopefully cover all the serotypes that are, and they are in production right now. So maybe in the future those will be available to people. But Paul, this was a great episode. People can go back and listen to the full one if they have more questions about this. But thanks to all the listeners who have recommended this. We finally got around to doing it, but people had been asking about a travel medicine episode for years, and I felt it was really helpful to my practice as well.
Same.
All right, Paul, we have a couple listener questions. So the first one is by your Alastincalizumab.
You're a little stinky losumab, Matt.
Yeah. Okay. I'm sorry. It's that was a hard word for me to say and to read. Okay, Paul. So, hi, Curbsiders. Love your podcast. Thanks for making me laugh and teaching me at the same time. Two questions, but we're just going to get to one of them here. Um, can you do a quick tutorial on how to basically digest the data from continuous glucose monitors and how to adjust insulin? Paul, we talked about this with Colburn recently. So how are you approaching this?
So it's for me, it's you're looking at the specific patterns, and you can go back to our episode to actually sort of address this. You want to target hyperglycemia in general by addressing the fasting blood sugar is the thing that I kind of go at. It's my approach is probably not going to be all that different from your Lostinkaluzumab, to be honest with you. I think you can still use the same data that you would if someone brought you in the blood stained log. This way, you just feel a bit better about it because it's coming from a computer, not coming from the patient writing things down themselves. But targeting hypoglycemia first, or basal or fasting hyperglycemia by addressing the basal insulin, and then sort of chasing down the postprandial excursions with your fast acting insulin if you need to. Though these days, I don't. We've talked about this before, and I know this is outside the scope of this question, Matt, but I don't do a whole lot of prandial insulin these days. I tend to favor GLP-1 agonists or targeting sort of the largest meal as opposed to doing the fancy meal calculations and sliding scale, which I'll save for endocrinology. How are you using these things? I use the more kind of general sense of control than I do to specifically target dose changes, if I'm being honest with you.
Well, in some patients, I use them to target dose changes, but the main thing that I find them helpful for is identifying points of hypoglycemia, which often patients are missing when they're
Yep.
just doing the conventional finger sticks, especially ones that occur overnight. So, and like Paul said, the first thing you have to do before you start addressing any highs is you have to get rid of the lows, because sometimes just getting rid of the lows itself will fix things, because when you
Right.
have lows, your body tries to protect itself for the next 24 hours by making it insulin resistant. So if you keep having lows, it's going to worsen your insulin resistance and just worsen your A1C control, even though you're having lows. So that's why you got to treat that first. And that was a great point that Colbert made when we talked to him.
It's so well said, Watto. I have hitched my wagon to the right star.
Thank you, Paul. I look at the daily trends. It's an overlay graph, so it has like a thin black line usually that will say sort of like where their average is at certain times of day, and then it has like a couple shaded lines that show sort of the variation that they might have. And you can usually identify some peaks throughout the day and say, hey, like looks like your breakfast, you're kind of peaking after breakfast every day, or what are you eating for dinner? Your dinners look like it's high, and that sometimes that'll lead me to adjust, if they're on mealtime insulin, to adjust their mealtime insulin for specific meals. But like you, Paul, I try to, if it's especially for type 2 diabetes, I try to avoid mealtime insulin. And I try to use like either SGLT2 inhibitor or a GLP-1 agonist to control postprandial. But I will use basal insulin if needed in people with type 2 diabetes. But hopefully, most of my patients are now avoiding the 3 or 4 times a day insulin. All right. Well, thank you. And that is episode number 433, CGM's insulin and how to adjust medications based on glucose patterns. That's with Dr. Jeff Colburn. So check that out. How do you say that name again, Paul? You're all a stinky lizumab?
You're a little stinky, Lizumab, I believe.
You're a little stinky lizumab. Okay. All right. Howard asked us multiple questions. One of them was about PCSK9 inhibitors and inclisiran, saying that and just saying like, do these things actually have clinical benefit? And do you need to take it in addition to statin, or can it work on its own? Paul, do you have an answer to this one off the cuff? I know you didn't have much time to prep for this, which is my fault, but I was kind of doing some research on this ahead of time.
Yeah, I'd be curious to hear your approach. I can speak more to the PCSK9 inhibitors than I can to inclisiran, which I have not prescribed yet for any of my patients. And I will say the PCSK9s I have typically gotten approved by insurances because patients have had statin intolerance. I guess there has been the occasional case where you just needed this add-on therapy to kind of get people where they need to be, but by and large, this is for someone, where I've seen these used is either for someone who has clear evidence of familial hyperlipidemia and they're just not getting to goal with the statins that they're on, or for someone who needs secondary prevention and has statin intolerance and you need to get them much lower than they are. And those are the two circumstances where I've seen them, and they are incredibly potent. Like they are just as advertised. I have seen cholesterol come down really remarkably well with these agents, but I more commonly use them because I cannot use a statin than as add-on therapy or to actually get to a specific target. And I'm not sure, Matt, if that sort of aligns with your use of them or what you've seen in your practice.
Yeah, I mean, that's pretty much it. It's mostly they're mostly being given for secondary prevention, not primary prevention. And the big trials, there was the Odyssey outcomes trial, which, was with one of the two PCSK9 inhibitors commonly available in the US, and then the Fourier trial. And both of those had some long-term analyses. But it's important to note that the patients in both of those studies were also taking statins already, like a max tolerated dose of statin, and they all had cardiovascular disease, or they had to have like at least heterozygous familial hypercholesterolemia. So, like, it doesn't really tell us what to do for your patient who has no known cardiac disease and has statin intolerance and an LDL that's, elevated, and you're kind of some worrisome risk factors. So, and then the outcomes data, kind of looking that up just for the audience, a peek behind the curtain. I've been using both Open Evidence and Clinical Key AI, which are both these AI tools where you can type in a clinical question and then it'll give you a plain language answer, but with citations. And it seems like when they look back at those trials, they have not yet proven that they prevent cardiac death, the PCSK9 inhibitors, even in those subgroups, even for secondary prevention. It looks like they do help prevent like non-fatal MI and stroke. But one of the trials was not actually like powered to be looking at this. And so it was just sort of like a secondary analysis, I guess, post hoc analysis, and the other one was pre-specified. But we don't really have great like long-term outcomes. So I would love to get more data on this to just be as confident as we are in statin that these have benefit for people. Because certainly right now for primary prevention, I don't think we have enough to say, how good they are. But for secondary prevention, I think they've become a standard already. So I'm not sure how much more they're going to study it, but I think we should study it more. And then our other question, kind of an add-on to this, was from Tulsa Doc Girl asking, a cardiologist told their patient to get their LDL below 44. And this is a person with a calcium score of 77. So I guess you could say they do have at least some start of coronary disease. So, Paul, what do you think about this LDL of 44?
And I do not know.
Yeah.
It's not a number that I'm aware of and that is guideline driven, at least. And I'm sure that the cardiologist has a good reason for choosing it. Perhaps it's based on a very specific study. And I hope listeners will correct me if I'm mistaken. I mean, the numbers that I'm aware of for these very high risk patients, I think the most recent update, the ACCHA guidelines recommend less than 55 milligrams per deciliter, for high risk less than 70. And I think for a lot of folks, you just want to try to shoot for less than 100, even though I know we're not very goals based these days. But the 44 is so specific, I don't know what it might be referring to.
Yeah, and the AI programs couldn't find it either, and I wasn't aware of one. But the numbers that stick out in my mind are generally the less than 55. The ACE guidelines had that way back in like
Yeah.
2017. The European Society of Cardiology has that in their 2019 guidelines, and this is for people that are very high risk or have known coronary disease. Get them as basically the lower the better. And there's been some like articles that and just people, there's an article about like LDL cholesterol, how low should we go? This was by Tobert, Tobert, and this was in 2022, saying that maybe for people that like have an MI, even if their LDL is already below 55, maybe you go below 40, but I didn't find 44 anywhere. So basically, try to get them as low as you can within reason, I guess. Paul, are you seeing people like make an arbitrary cutoff of like how low is too low?
Not, I have seen, we were talking a little bit before recording. I've seen some neurologists get nervous about the idea of spontaneous intracranial bleed at very low LDL levels. I don't think the studies are super definitive about that. And I will say, I know that when the PCSK9 inhibitors first came out, the landmark trials that looked at those, one, they were important because they showed how effective these medications are, but two, they showed that you can push LDL pretty low and then actually results in pretty good cardiovascular outcomes too. So I'm probably a little bit more cavalier than my neurology friends, but I also want to work with them and not scare my patients, and certainly would not want something
Yeah.
catastrophic happening. So you just sort of, you go as low as everyone is kind of comfortable going, I think, which is, is going to be a little bit variable.
Yeah. All right. So a little diabetes, little cholesterol, these seem to be pretty common things. So that's why we wanted to answer them. I mean, people love asking us about these on these AMAs. Paul, um, let me go first for picks of the week.
Yeah.
So did you watch WWE or WWF as a kid?
You bet. Absolutely.
Yeah. So you need to watch the Mr. McMahon documentary on Netflix if you haven't already. I know you generally don't watch TV shows, but this is a docuseries kind of documenting the life of Mr. McMahon and sort of the creation of the WWE. And then at the same time they were doing this docuseries, these allegations came out about him with sexual misconduct. And it's just fascinating because he's being interviewed in 2021 and then 2022 and again in 2024. These allegations came out. And I mean, just the Mr. McMahon character that he plays on the WWE shows like Raw or SmackDown or whatever they
Mhm.
have nowadays. I haven't watched for like 20 years. It is fascinating the fact that like a lot of the storylines that he was supposedly involved in as his Mr. McMahon character are like legit things that were just going on behind the scenes. And it's
Huh.
just it's insane. Yeah, Paul, there's these just storylines where how he's cheating on his wife, and things like that. And then this was all happening in real life with some of the, the women who were involved in WWE and just his abuse of his power. It's fascinating. As someone who grew up watching wrestling, for me in sort of the 80s and then the 90s, and I sort of stopped as like once I got to college, I guess in the early 2000s. But
Yeah, it's weird how this wrestling has had a resurgence. Like it used to, like exactly you say, like in the '80s, like it was huge, and then I think it kind of waned off. And there was sort of now an increased interest in it again. So it's super interesting. Fun fact: my great grandmother was extraordinarily hard of hearing, and so her favorite thing in the world to watch on TV was wrestling because you didn't have to hear any dialogue at all. So those are my scant memories of my very, very, very old great grandmother is mostly sort of watching wrestling and enjoying that. So anyway.
I'm headed there. I have to watch everything with subtitles now. I feel like I get more out of a show if I have subtitles on. Paul, what are you recommending?
I'm going to do two music picks of the week, if that's okay with you, Matt. So
Sure.
because I can't remember if I've recommended Clutch before. We've done too many of these shows, but anyway, I'm going to recommend the specific. So Clutch is a rock band out of Maryland. They've been around for a million years. That I've been a huge fan for forever from their first album, One. They started out as kind of a hardcore band, and then have their second album was this complete turnaround that was sort of very groove heavy and had kind of blues feel to it, and was just sort of goofy and songs about being on a pirate ship and stuff. They're phenomenal. Like they're great to see live. They've done like I can't remember, like 13, 14 studio albums now at this point. But the one I'm going to highlight is one called Psychic Warfare, which came out several years ago, that has just a lot of great songs. It's kind of emblematic of all the things I like about them. These great sort of sing along choruses. The lead singer is kind of a storyteller, just about someone who is found to be having an affair with a woman and gets caught by her husband. And there's a whole song called Quick Death in Texas about that, which is just delightful. Like it's funny, but has like, it's sing alongable. It's got these great choruses, great guitar, very sort of like ZZ Top inspired. So good stuff. If you're not familiar with Clutch, I would recommend starting there as a place to maybe check them out. And then the other one I'm going to recommend is A Complete Left-Hand Turn. Do you like Harry Nilsson, Matt? I know this is sort of a strange question.
I know that name, but I couldn't tell you who he is.
This is the entire experience. He has written so many songs that you have heard and are famous that you would not be able to pick him out. Like, you just know that you know it. So the coconut song, you put the lime in the coconut.
Oh,
He wrote One is the Loneliest Number, which
oh
the,
yeah.
the title is One. That Three Dog Night made a huge hit out of. He did the song Without You. He was the Beatles, one of their favorite artists, and you can tell he's sort of inspired by them, or they inspired each other. But he did an album that was also a movie that played in the 80s called The Point, and it's this fable about this little boy who lives in a village full of where everything has points and they have points on the top of their head, and he was born without a point. And the point of the movie is even things that don't seem to have a point actually have a point. But the songs are incredible and just again very sing-alongable too. The original cartoon was actually narrated by Ringo Starr, and like Alan Thicke did like the more updated version. But the songs are amazing. It had Me and My Arrow as part of the soundtrack, which you may have heard about. My favorite song is Think About Your Troubles, but it's just he's got this incredible voice. The songs are all just absolutely beautiful. And he was a wild man. If you ever get a chance to read or learn more about him, like he wrote these beautiful songs, but just partied hard and died young. But interesting guy, incredible voice, great songwriter. So Harry Nilsson, and The Point specifically, I'll recommend. But he's lots of albums of stuff that you've heard, but you just didn't know that you heard.
All right, Paul, we've run long, so it's time for an outro.
This has been another episode of the Curbsiders, bringing you a little knowledge food for your brain hole.
Yummy?
Great. Classic. You can find our show notes at thecurbsiders.com and sign up for our mailing list to get our weekly show notes in your inbox. This includes our Curbsiders Digest, which recaps the latest practice-changing articles, guidelines, and news in internal medicine.
And a special thanks to all of you, all our wonderful patrons, for helping to support us and make it possible for us to do this show. Our technical production is done by the team at Podpace. Elizabeth Proda does our social media. Jen Watto runs our Patreon. Krista Chu-Manchu moderates our Discord. Stuart Brigham composed our theme music. And with all that, until next time, I've been Dr. Matthew Frank Watto.
And as always, I remain Dr. Paul Nelson Williams. Thank you and goodbye.